Good morning, everyone, and welcome to the final day of this year's Kidney Action Week. My name is Mike Spigler, and I am the Vice President of Patient Support and Education for the American Kidney Fund. The past several years, ACAF has seen the world of kidney disease advancements grow tremendously. Today, we know you'll leave Kidney Action Week feeling hopeful about what the future holds. Before we get started with our first speaker, I want to encourage everyone joining to please type your questions and comments into the chat box to the right. We will try our best to get to your questions during our Q&A segment at the end of this talk. To start us off today, I'd like to welcome our first speaker, Dr. William Fussell. Dr. William H. Fussell is an Associate Professor of Medicine in the Division of Nephrology and Hypertension within the Department of Medicine at Vanderbilt University Medical Center and Medical Director of the Kidney Project. Dr. Fussell's research group has focused on technology development to treat kidney failure, and his team developed a completely novel biomimetic membrane for blood filtration that functions just like a kidney's filters. Dr. Fussell is unable to join us today, but we have a recording of him talking to us about his research, and will also be on for questions at the end of the first four presentations.
Good morning. I'm William Fussell. I'm an Associate Professor of Nephrology at Vanderbilt University Medical Center in Nashville, Tennessee. And I'd like to thank the American Kidney Fund for giving me the opportunity to pre-record this talk today, because at the actual time of Kidney Action Week, I am planning to be off-grid. I'm going to spend a couple minutes telling you about the research that I've been conducting over the last 20 years to try to develop technologies to assist patients with end-stage kidney disease. So at the end of the talk, and this is going to be a very fast kind of 15-minute flyby of 20 years of research, you'll have some familiarity with our design rationale and why we made the choices that we made. And really, this reflects the criticism that kidneys are very complicated organs and that it's a very steep hill to try to engineer a replacement for kidney therapy. I'm also going to then move on to some technical details about the two major components of our implantable artificial kidney, or our universal donor kidney. The first is working out how we can make an implantable device that will last in a patient. And so that means managing the interactions between the patient's body, the patient's immune system, patient's blood, and the artificial materials that make up an engineered device. Then I'm going to probably get a little more technical and talk a little bit about our work trying to perfect the performance of kidney tubule cells when they're grown in an artificial environment. I'll close with a little teaser of one of the first in vivo demonstrations of our technology. And then I'm going to just close with some thoughts for the future. So if you were looking for a kidney, if your kidneys didn't work, you would probably want a kidney. And you might be hoping for a kidney transplant. You might be using dialysis as a bridge to transplant. You might be using dialysis to sustain your life. But if you really wanted a kidney, if you're going to put a help wanted ad in the newspapers, or you're going to visit the dating page on Craigslist and advertise for a kidney, what would you want that kidney to be able to do for you? And as I torment my nephrology fellows all the time, kidneys perform about a dozen homeostatic functions to keep you safe. They control your extracellular fluid volumes. It's one of the reasons why you weigh yourself when you go to dialysis. They control your red blood cell mass by secreting erythropoietin. They hydroxylate vitamin D. They control your body's acid-base test. They control your body's bone mineral metabolism. They control your electrolytes, potassium. And they get rid of waste products. Our experience with 50 years of managing end-stage kidney disease with dialysis has shown us that out of these myriad functions that the kidney does for us, we can replace all but two of them with medicines and with an environment of care. The two things that are essential that we absolutely have to do is we have to be able to measure monitor, and control fluid volume. We have to be able to get rid of waste products. Everything else, from vitamin D to acid-base status to potassium, we can manage using the environment of care rather than a physical device. And so that collapses the challenge from trying to make an entire artificial kidney to focusing on specific things that we need to accomplish. The little stick figure on your left here is urea. It's the waste product of protein metabolism that nephrologists use to assess kidney function. They use it to assess adequacy of dialysis. And in a nutshell, your body makes a lot of urea. And so your kidneys are constantly cleaning your blood. 100 ml a minute of blood is completely stripped of urea every minute around the clock. That adds up to hundreds of liters a day of blood that's processed and cleaned and returned from the kidney back to the body. So we can't possibly have a universe where we urinate 173 liters a day. We're not fish. We're not swimming in water. The way dialysis approaches the problem is it washes the blood with a huge volume of dialysate. So 170, 200 liters of dialysate in every single dialysis session. The challenge with that is that using this washing strategy, you're tethered to the fireman, to the fire hose, to the fire truck, to the fire hydrant. It's a fundamental barrier to mobility. And then you also have to get this all done in a short period of time. Move the patient through the dialysis unit. In contrast, the kidneys work this out like wringing out a towel. They process 170 liters a day, but you only excrete 1% of that. 1.7 liters of yellow juice goes out in the toilet bowl. So that clarified things for us in terms of design. We need to filter blood, and we need to concentrate the waste products in that filtrate down from tens or 100 liters a day, down to a manageable volume that you could conceivably urinate into a toilet bowl every day and balance with oral intake of food and fluids. So when you think about a kidney, down here at the bottom, there's the filter right here, the glomerulus. There's the proximal tubule, convoluted and straight, that performs the large majority of fluid balance and fluid reabsorption. And the whole rest of the kidney, the loop of Henle, the distal convoluted tubule, the collecting duct, is responsible for fine-tuning volume management, is responsible for osmolar balance, all of these other things that we can replace with an environment of care. So that simplifies our kidney engineering challenge to making a filter that filters and coming up with a strategy to concentrate waste products from the filtrate into something like urine. We don't have to accept the complexity of a real kidney. We can simplify things based on what we've learned from 50 years of dialysis. So we set about making a filter. The conventional filters that we use in dialysis aren't suitable. They're too big. Try to think about putting a dialysis cartridge inside you somewhere. They also require too much pressure to move blood around, to filter blood, hundreds of millimeters of hydrostatic pressure. So all I did, my sole contribution to the field, was bringing a technology that's industrially mature, called silicon nanotechnology, and make a membrane out of it that looks like a kidney's own filters. These elongated, uniform, slit pores that resemble the glomerular slit diaphragm. On the left, you see a scanning electron micrograph of one of our very early filters that we snapped, and that's in cross section with the blood side on the top and the filtrate side on the bottom, and these very smooth, uniform pores that are the same size as albumin. On the right, there's a cartoon depicting how we used another industrially mature technology, computational fluid dynamics, to engineer a cartridge to carry these filters so that we could transform the round pipe flow of blood vessels into the parallel plate sheet flow that our underlying technology of silicon membranes required. And inspired by the work from the mechanical circulatory support community, we were able to engineer a device that controls the fluid shear stress of blood in the device so that blood doesn't sit and coagulate and blood isn't damaged by high flow rates. So that's the filter side of the equation. Let's talk about the cell side of the equation for a moment. People have asked me for dozens of years, why are you so interested in doing this with cells, Bill? Come on, we have dialysis. Well, kidney cells evolved to do this very concentrating function. They reabsorb salt and water and amino acids and glucose, valuable nutrients that your body needs, and they reject the waste products that make you sick in renal failure. And we don't even know the identities of all of these waste products that make you sick, but your kidney tubule cell knows because it rejects them all. And what's more, it does this process using the chemical energy of your body's own metabolism, rather than relying on electric motors and pumps and wires or drive lines or sorbents or any of the other techniques that we've seen out there that attempt to miniaturize or make portable the dialysis systems of today. The challenge here is that on the left, from Heptonstall's pathology of the kidney, you see a healthy kidney tubule cell with all of the mitochondria and the beautiful, lush brush border at the top. And on the right, you see that exact same cell when you grow it in an artificial environment. And I don't know about you, but if I was going to the supermarket to buy a tubule cell, I would probably pass over the one on the right and buy the one on the left. So for 20 years, I was told, Bill, it won't work. Yeah, okay, fine. You fixed the clotting issue. Never mind. Your project will not work because cells do not grow the same way in the dish as they do in a human. And the epiphany that I had was that it wasn't a fundamental fact of nature. It was that no one had grown tubule cells in an artificial environment with the intent of getting them to function as they do in a healthy kidney. We learned how to grow tubule cells. We learned how to grow epithelial cells full stop as a vehicle to grow poliovirus for vaccines and as a tool to decipher gene regulatory pathways in cellular physiology. We didn't learn how to grow tubule cells to achieve function. So that's what we did. I'll skip over the details here, but we chose one particular transporter that's essential for the reabsorbing function of the kidney. And that's a chemical called NHE3. And we were able to coax the cells to produce it both at the genetic level, at the protein level, and you can see it here in red in the imaging. We then went on to show, sorry, I didn't mean that to advance. We then went on to show that these cells in culture transport salt and water by expressing the protein at the gene level, at the protein level. We're able to show that cells, when we coax them using the right chemical environment, we're able to transport salt and water, seen here in this bar, and we could block that transport with a diuretic drug. So by simply asking the question in a different way, we were able to overcome a fundamental objection to our project, that the cells would not function in the way we needed them to. So armed with that, we went on to make a very small scale bioartificial kidney that was a hemofilter of our silicon chips and a bioreactor of our cultured cells You can see it here held in the experimenter's hand. We went on to implant that in a pig. Here's the hemofilter, here's the bioreactor. You can see the blood coming from the pig's aorta and vena cava, goes to the hemofilter, it's channeled to the bioreactor and then back to the pig. The ultrafiltrate from the hemofilter is directed to the bioreactor, and then out of the bioreactor, the concentrated filtrate is directed to the bladder. Then we sewed the pig shut, put the pig back in the cage, came back 48, 72 hours later, and examined the artificial kidney, extracted this tube out of the bladder and looked at it, and that's a drop of concentrated filtrate or urine that our little implantable bioartificial nephron had been making over the 3 days of the experiment. So in closing, there you have it. We brought new technology to nephrology with the silicon nanotechnology hemofilter that does away with the need for external pumps that tether you to the fireman, the fire hose, the fire truck, and the fire hydrant. We use human renal tubule cells to concentrate that filtrate. And again, that frees you from the fire hose, the fireman, the fire truck, and the fire hydrant. I didn't discuss it at length, but the way that we grow the cells means that we do not need to give the patient immunosuppressive drugs. So patients who are in that awkward window recovering from a malignancy can still receive our device. And we've assembled these into a bioartificial nephron that we hope to expand into a universal donor kidney so that every single patient with renal failure can receive a device that will be enough like a kidney that combining the device with the environment of care will free them from dialysis. My aunt had polio. When she was an infant, she spent a while in an iron lung. We don't use iron lungs often. They're museum pieces. And I would like to take dialysis machines and have them in a museum alongside iron lungs, pioneering life-saving devices that saved people's lives, but are no longer how we take care of patients today. Pim Kolff was the first physician to successfully dialyze a human being and recover a patient from acute kidney injury. He said it's nearly impossible to obtain funding for something simple. Therefore, over the years, my laboratory has teetered along, always on the rim of bankruptcy, always having too many ideas and too little money to carry them out. And that's the situation that our team has found ourselves in for the last 20 years. We desperately need funding to take our advances and bring them to patients within the lifetime of somebody with kidney failure today.
Well, thank you very much, Dr. Fussell. I agree. It's exciting to think about a world without a lifetime of dialysis for patients. We're going to move right on to our next speaker, and I want to bring in Dr. Samira Farouk. Dr. Farouk is an associate professor of medicine and medical education, associate program director of the Nephrology Fellowship Program, and social media director of the Division of Nephrology. She is a board-certified transplant nephrologist and internist. She's interested in the development and study of innovative medical education tools and technologies, including free open access medical education and social media. She is the co-founder of NephSim, which you can find at nephsim.com. And Dr. Farouk is here to shed some light on providing transplant care to transgender patients and ways to advocate for oneself. Dr. Farouk?
Thank you for the introduction, and thank you so much to the American Kidney Fund for highlighting this very important topic as part of Kidney Action Week. And so I'll be talking today about transplant and also kidney care for the transgender patient. Here are my disclosures. I won't be discussing any of these in the session today. So in the next 15 minutes or so, I'm hoping to cover three broad objectives. And so the first is to discuss potential challenges that may present during a transgender person's journey from the pre, peri to post-transplantation period. The second is to describe the potential impact of gender-affirming therapy and therapy on transgender people who may ultimately undergo kidney transplantation. And finally, and this is not, of course, specific to transgender individuals, but recognizing and a reminder of the importance of a safe and welcoming environment to provide culturally competent care, and to share some tips towards the end to empower our patients to advocate for this inclusivity for their own care. And so I'd like to frame this with a case, and this is inspired by some real patients that we've taken care of at Mount Sinai. And this is a 55-year-old transgender woman who has a history of diabetes, high blood pressure, chronic kidney disease, who's presenting to our transplant nephrology clinic for initial evaluation for a kidney transplant. She is notably receiving gender-affirming hormone therapy, and we'll talk a little bit about what that means and what the goals of that are, including oral estradiol as well as spironolactone. And notably, she also has not received any gender-affirming surgery, though she hopes to sometime in the future. And so if we take a step back for a second, what does gender really mean? And that's, I think, very important as we talk about transgender individuals. And so gender, which is different from sex assigned at birth, includes our gender identity, our expression, and our gender roles. And so cisgender individual is someone whose gender identity aligns with the sex that they were assigned at birth, whereas a transgender individual is one whose gender identity does not align with the sex that was assigned to them at birth. And you can see here this graphic of the gender unicorn, and I won't go through each component of this, but the idea here is that gender really comprises several different spheres that really all work together. And gender is not binary, so it's not just man or woman or male or female, but rather exists on a spectrum. And so transgender individuals may identify somewhere on this spectrum, and there's different language here, and I won't go into all the differences, but the idea here is that to provide the best care for our patients, whether they have kidney disease or not, we need to really understand that our patients may fall anywhere on this gender spectrum, and being able to understand that and to acknowledge that is really important in creating a safe environment for our patients. And so how many individuals in the US identify as transgender? And so if we look within a subset of LGBT adults within the US, about 10% of those we think identify as transgender. And a recurring theme that you'll hear in the next few minutes during this presentation is that our data here are very, very limited. And that is one, because of the type of data that we collect. And the second is that individuals may not feel safe sharing their gender identity, as they may feel that it has other implications. And we'll talk towards the end about some of the challenges that transgender people face, particularly within the healthcare environment. So how do we estimate how many transgender individuals in the US are living with kidney failure? And again, our data are limited. And I'll first draw your attention to this figure on the right. And this is showing us, and this is data from the US RDS, which gives us data about individuals that are living with kidney failure in the United States, and can be very enlightening to understand who is receiving hemodialysis, who is receiving peritoneal dialysis, who is receiving a transplant. And you'll see here that when we look at this variable of sex, which notably is not gender, we only have two categories here, female and male. So if we try to begin to answer this question of what is the prevalence of kidney disease in individuals with that identify as transgender, we really cannot answer that. But we can try to make some estimates. And so I'll draw your attention now to the left side here. This is data from the CDC reminding us that more than 1 in 7, or about 36 million individuals, are living with chronic kidney disease in the US. And so we might estimate, given the prevalence and the number of individuals that identify as transgender, about 10% of the LGBT population, that maybe about 176,000 of individuals are transgender living with chronic kidney disease. And so using the numbers above, 4,000 of those are probably living with end-stage kidney disease. And so how many of those individuals have a kidney transplant? We really just cannot answer that question. And so more data are needed to better understand and study this population, again, to ultimately provide the best care for them. So I'm going to spend the next few slides talking about the importance of the serum creatinine, which many of you may know is what we use to estimate one's kidney function. And that number, the eGFR, or estimated glomerular filtration rate, is very important for the diagnosis of chronic kidney disease, dosing of many drugs, and most importantly in this context, one's eligibility for even receiving a kidney transplant. And so this is a screenshot from what we would call an eGFR calculator. And you can see that there's three variables: the serum creatinine, the serum cystatin C, which is another marker that we can sometimes use, as well as the person's age. And so many of these calculators and equations that we use also include a sex variable. And so I've included for comparison on the left side the results if we say that somebody is male, and on the right side if we say that somebody is female. And so depending on the kind of equation that we use, we see that the female eGFR is a bit lower. And so you can see here in this first example that the male GFR is 26, whereas the female GFR is 19. So as a transplant nephrologist, this is a really important cutoff, as the eligibility to be active on the wait list for a kidney transplant from a deceased donor is less than 20. So depending on the sex coefficient that we use, the eligibility becomes different. However, if we look at this equation on the bottom, which does not use the creatinine, but uses something called cystatin C, the differences are a little bit less. And so serum creatinine is sometimes a reflection of one's muscle mass. And we'll talk about in the next few slides why for transgender individuals, and particularly those that are receiving gender affirming hormone therapies, their serum creatinine may actually be different while not really impacting their kidney function. And so here are some recommendations from experts that have studied this field that suggest that for individuals that are transgender, we should really look at both eGFRs using both the male and female coefficients, and then really have a shared decision-making process with the patient about which one is maybe a more accurate reflection. And there are other strategies to perhaps come up with a more precise estimate of the kidney function. So I'm going to transition a little bit now to gender affirming care, because to provide the highest level of care for this population, we really have to understand what gender affirming care means and why it is so important to affirm what one's gender identity is. And so we talk about the transition of gender in these two categories. So one is the non-medical transition, and then the other is the medical. And so for this session, we're going to focus on the medical transition and talk about what the potential implications would be on a potential kidney transplant and the post-transplant care. And so that falls into two subcategories, one which is hormone therapy, and the second which is gender affirming surgery. So the gender affirming hormone therapy has two goals. And so the first is to decrease one's endogenous sex hormones. And the second is to replace or shift the sex hormone configuration to reflect what is one's affirmed gender. And so I also want to share a reminder here that not all transgender individuals are taking gender affirming hormone therapy, and not all transgender individuals are going to ever receive or want gender affirming surgeries. However, there are some patients that will, and that's why it's important for us to understand this. And so you can see in these graphics below the types of hormone therapy that individuals may be taking. So these may be pills, they may be injections, they may be patches that go on the skin, and also gels. And so important for us to understand what our patients are taking, and again, create a safe environment that they feel comfortable sharing with their providers what it is that they are taking, so we can understand any potential impact on how we interpret the data, particularly for kidney function estimation. And this was a nice study that was completed a couple of years ago in the pediatric population, showing that individuals that are taking gender affirming hormone therapy are going to show an impact on their serum creatinine and their kidney function estimation, but not their real kidney function. And that is, again, what we think is due to this impact on the muscle mass. So you can see here on the left-hand side, these are transgender women, and they were designated male at birth after they begin taking gender-affirming hormone therapy. So for example, estradiol, likely their muscle mass decreases and the serum creatinine decreases. However, their kidney function has not changed. It is just their serum creatinine that has changed. And you can see the opposite is true for those individuals who are transgender men who are taking testosterone therapy. You can see that the serum creatinine rises, and this again does not reflect a change in kidney function, but rather their kidney function estimate. And so a different type of gender affirming therapy would be a surgery to affirm one's gender. And I won't read to you the different types of surgeries here, but the idea here is that we need to really understand what surgeries have already happened to understand one's anatomy. Of course, there is a surgery involved with kidney transplantation. And so our entire transplant team needs to understand how the anatomy may be different. And some of these procedures can actually have an impact on kidney function. You can see, for example, here, individuals that may receive breast augmentation may be at higher risk of developing acute kidney injury or elevated calcium levels if they have received silicone injections, for example. And so again, the key here is creating this environment so that an individual is willing to share with you surgeries that they have had, surgeries that they may want to have in the future, so that we can time those, again, with the goal of affirming one's gender identity. And so open discussion and shared decision making really are critical. And I'll come to close to the end here with some sobering statistics about the challenges that not only transgender individuals, but many marginalized populations feel and the discrimination that they may experience in the healthcare setting. And there are numerous studies that have shown this data to be unfortunately true time and time again. And this is data from a US transgender survey about 10 years ago, but I'll tell you that these numbers have unfortunately not really changed. And you can see here in several of these really eye-opening categories to me: negative healthcare experience, living in poverty, physically assaulted, unemployed, and have attempted suicide. These numbers are markedly higher in individuals that identify as transgender. And so it's really incredibly important for us to think about this in the healthcare setting, and how can we remove and decrease barriers to care to try to provide the highest quality of care for these individuals. And I could show you another slide showing you that comorbidities such as diabetes, heart disease, kidney disease are also more prevalent in this population. And so when we put these two things together, it really seems that we need to work hard on a solution to try to not only provide high-level care, but also optimize opportunities for successful and preemptive kidney transplantation for this group. And many of you have also, I'm sure, seen in the news that transgender individuals are probably facing even more discrimination now in the healthcare setting. And this may vary based on where they live, but there has been nationally a rise, unfortunately, in anti-trans bills. And you can see here lawmakers in 37 United States have introduced 142 bills to restrict gender-affirming healthcare for this population. And that is tripled if we compare that number from 2023 to 2022. And so again, just really a call for advocacy here, and the importance of understanding what gender affirming care is, why it is so important, and the steps that we can take really starting at an individual level to try to improve the healthcare experience for this group. And this is a slide that we could really put in any talk related to healthcare. In any situation, shared decision making is critical, and taking care of transgender individuals is no different. And so really partnering with your patient to find and compromise and what is the best care plan for them and how that can be individualized. And so one example of this, particularly in the transplant setting, is what do we do with one's gender affirming hormone therapy in the peri-transplant period? Should we stop it? When should we stop it? When should it be restarted? And the short answer, without showing you the data, is that we really need to have this conversation with the patient, explaining to them what are the risks and benefits based on the data that we have, and having all that information moving forward and making a decision that works for the entire the patient, the patient's care team, and thinking about what the future of that clinical scenario may be. And so to end, here's my final slide, some key takeaways. So the first, gender affirming care affirms and supports one's gender identity, which lies on a spectrum and is not binary. And so if you're never asking your patients these questions, you will not know if they are someone that is taking gender affirming hormone therapy, or planning to, or has had a surgery in the past. The kidney estimation equations, unfortunately, at this time do include sex, and there is ongoing work to try to improve these equations and think about a more accurate way to assess kidney function. And so interpretation of our current kidney function estimates, including transgender individuals, really requires open discussion between patients and care providers. gender-affirming hormone therapy can impact serum creatinine. And so to know if that impact may be there, you have to first know that your patient is taking gender-affirming hormone therapy. So how can you create an environment to be able to obtain that information? And then finally, this is a problem that cannot be fixed overnight, but transgender patients unfortunately experience numerous barriers from accessing healthcare. And so this is a look to the future. What can we do to try to improve those barriers, not only for this patient population, but all the patients that we see in the nephrology community. So thanks for your time, and looking forward to answering any questions y'all might have at the end of the session.
Thank you so much, Dr. Farouk. Your learnings and research are really a step in the right direction of inclusive healthcare, and we appreciate all that you shared about the existing research. As Dr. Farouk said, if you're just joining us, welcome to our Innovation Showcase session, and you can put your questions in the chat box right now. We will have some time at the end to ask questions of all four of our speakers. Just type your questions there, and they'll be sent over to us as we get moving. So along the same lines of newer research, our next speaker is here to share about a novel topic in kidney disease, chronic kidney disease of unknown etiologies. To do that, I'd like to welcome Dr. Pablo Garcia. Dr. Garcia is a past AKF clinical scientist and nephrology fellow from 2019 to 2021, and he's currently an assistant professor in the Division of Nephrology at the University of New Mexico School of Medicine. Dr. Garcia has a special interest in global health nephrology, COVID-19 in patients on dialysis, chronic kidney disease of unknown etiology, and tubulointerstitial kidney disease. He's also interested in understanding and studying chronic kidney diseases in settings where patients have limited access to medical care. Dr. Garcia?
Thank you. Thank you. So I'm very excited to share with the community of providers and also patients or caregivers who have chronic kidney disease. I would like to share a little bit more about chronic kidney disease of unknown etiology. We can move to the next slide. So conflict of interest, consultant for Cardias Therapeutic in the past. This is unrelated to this talk. We can move to the next slide. So I will talk about the chronic kidney disease of unknown etiology, the hotspot specifically. I would like to give some examples where chronic kidney disease became chronic kidney disease of known etiology. I also will talk about the chronic kidney disease of unknown cause in agricultural communities around the world, some of the prevention strategies that are currently being implemented, chronic kidney disease in the United States, specifically the chronic kidney disease of unknown etiology. Next slide. So here is an interesting map. This map is showing some of the areas where we can identify some of these chronic kidney disease of unknown etiology hotspots. What do we mean by chronic kidney disease of unknown etiology? We mean that there is an increased prevalence of chronic kidney disease in specific areas, and this population that is affected by chronic kidney disease is not the population that we usually see with chronic kidney disease, with diabetes, high blood pressure. They don't have any of these risk factors. Generally, they are young population. Could be women, could be men. So we have Mesoamerican nephropathy. Mesoamerican nephropathy is located mainly in Central America, Nicaragua, El Salvador, Panama, Costa Rica, and Guatemala, some areas in Mexico. We have the aristolochic acid nephropathy that was very prevalent in Belgium and also in other countries like Taiwan and China. So then we have the Udanam nephropathy in India and chronic kidney disease of unknown etiology in Sri Lanka. There are other examples of chronic kidney disease of unknown etiology, lead nephropathy, and Itai disease. So now we can move to the next slide. So I would like to talk a little bit about history, because I think that nowadays we're dealing with this chronic kidney disease of unknown etiology that shares similarities in different countries. So the Balkan endemic nephropathy was first described in the 1950s. It was affecting people living in rural areas in Bosnia, Bulgaria, Croatia, Romania, and Serbia. As we can see on the map on the right side, there are a few areas highlighted with orange that you can see where those spots with chronic kidney disease were found in those areas. When they did biopsies or they analyzed the tissue on these patients, they found that they were affected mainly by something that we call the chronic tubulointerstitial disease. And it was affecting families in the same regions. the same men and women. The population were mainly farmers, at least 20 years in the area. Next slide. So then, in the meanwhile, in the 2000s in Belgium, there was this increase in the prevalence of chronic kidney disease, but it was specifically in people who went to a weight loss clinic in Belgium. So they were not completely sure what was the etiology. This patient didn't have the risk factors that we know about for chronic kidney disease, like diabetes, and they were young patients. So they found that some of these weight loss herbs had what we call the aristolochia, which is something that at that time they were not completely sure can cause chronic kidney disease or damage to the kidneys. Anyways, they did a very interesting research approach. The epidemiological work done in this was very impressive, and they were able to identify that the people who had chronic kidney disease or also urothelial carcinoma associated with it was associated and it was caused by the aristolochic acid that comes from this herb, that is the aristolochia. So they found that there were DNA adducts on the kidneys of those people who unfortunately had to undergo a nephrectomy, or they removed the kidneys because they developed kidney cancer. And that's how they identified this herb as a etiology for the chronic kidney disease, or a cause for chronic kidney disease. So then we can move next. So in the meanwhile, Balkan endemic nephropathy, they didn't know exactly what was happening. We know that based on some of the historical facts, and that Ivic, which was one of the researchers in the area, suggested that maybe the chronic aristolochia, which is this herb poisoning, was associated with the chronic kidney disease, because he observed that some of the seeds were mixed with all the local wheat fields, and also so he thought maybe this could be, but however, this was ignored, and or I'm not sure if it was ignored, but it was in 1969, and they didn't follow up with this. There is also some data or veterinary literature in Yugoslavia that revealed that the horses that ingested the hay mix with the aristolochia developed chronic renal failure, and that was from 1958. It was not until 2007 when maybe there was a connection. They realized that there was a connection between the herbs that they identified in Belgium in the 2000s as an etiology for chronic kidney disease, that they did this research, what was similar to the one done in Belgium. They noticed that there were a presence of the aristolochia DNA on the kidneys with people who developed chronic kidney disease and renal cancer in the Balkan area. So that's how they identified this as an etiology for the chronic kidney disease in that area. We can move to the next slide. Then connecting the dots, they also defined that the urothelial cancer found in Taiwan was also caused by the aristolochic acid as well. We can move to the next slide, please. So this is just to show you on the left side, we can see the plant that I'm talking about, or the herb that I'm talking about. And we can see the connection between the different countries, Belgium, the Balkans, China, and Taiwan as well. So this is important because now, moving forward, I will talk about the chronic kidney disease of unknown etiology in agricultural communities around the world. And perhaps there is a connection between all of these places, but we don't know yet, and I will talk more about it. So next slide, please. So the chronic kidney disease of unknown cause in agricultural communities. So in recent years, there have been numerous cases of chronic kidney disease that have emerged among agricultural workers and other performing manual labor, people who are performing manual labor in various regions in the world. So I will tell you a little bit about each of these places. Next slide. So when we talk about Mesoamerican nephropathy during the 90s, some clinicians in Central America, they noted that there was a large number of young sugarcane workers with end-stage kidney disease. They did epidemiological work, and they found that there was no diabetes or high blood pressure or other of the traditional risk factors in these patients. So they found that there was this chronic end-stage kidney disease of unknown etiology, and mainly affecting young people. Moving forward, we had some biopsy studies that showed interstitial nephritis, and then there are some possible etiologies, like, for example, some hypotheses, volume depletion, silica. We can move to the next slide, please. So here we have a little bit of in this review. I like the way that they identified possible etiologies. We have maybe toxins like pesticides, heavy metals. Silica nowadays has been there is a lot of research studies highlighting the presence of silica in the kidneys of people who are suffering chronic kidney disease in these areas. Heat exposure, which basically means that these people, unfortunately, are working in environments that are not the best, and they are suffering from dehydration, and the increased core temperature are going to cause kidney complications and potentially lead to the chronic kidney disease. And there has been some discussion about some of the infectious agents that are more prevalent in those areas where these kidney disease are seen. Next slide, please. So there is the Sri Lankan nephropathy as well. In Sri Lanka, this disease was first described in the 1990s, affects people working in rice paddies in rural regions. Men are more commonly affected than women, with an average age of presentation of 40 to 50 years. Most of the patients present with asymptomatic elevation of serum creatinine levels. There is low grade or no proteinuria, and when they do analysis on the tissue in the kidneys, they find that there is something that we call chronic interstitial nephritis, which can be associated with different toxins. And next slide, please. Then we have the Uddanam nephropathy, which is in India. There are numerous cases of CKD that have been reported among rural farmers in India. This is specifically in central India in states of Andhra Pradesh, Odisha, Chhattisgarh, and Maharashtra. The Uddanam nephropathy was named after a village in Andhra Pradesh. Chronic kidney disease in India this type of chronic kidney disease was first noted in the 1990s. People had normal blood pressure, low grade or no proteinuria, or protein in the urine. When they did some studies, or they had reports of renal biopsies, the same as what is happening in Mesoamerica, what is happening in Sri Lanka, it's a chronic dual interstitial disease. Next slide. And here, this table shows some of the hypotheses about what are the etiologies or the causes of this type of kidney disease. We don't know exactly yet what is the cause of this type of kidney disease, but there are some proposed hypotheses. Heat and dehydration could be one, exposure to pesticides, as I mentioned before, paraquat, or any other type of the pesticides that have been used in these fields. Heavy metals exposure, and as I mentioned before, silica, and also infections, NSAIDs, etc. Next slide, please. So what about prevention? So several groups in Central America are currently working with employers in the sugarcane fields to implement adequate rest, hydration during strenuous work periods in high-risk populations. In Sri Lanka, the government and other NGOs provide water-based interventions, like upgrading drinking water to public supplies or using reverse osmosis in water plants. Next slide, please. What about the United States? I think that I will highlight some of the most recent important research done in the United States about this topic. So here is something done it was done in Texas, and they look at people who had Mesoamerican nephropathy and people who had kidney failure from other causes. The main conclusions of this study is that they found some association between people who were exposed to agrochemicals, specifically paraquat or other agrochemicals. And this was found to be associated with Mesoamerican nephropathy. In the same research, they also reported some of the basic science that they did on this topic. And it seems like it can cause similar when they expose these mice with the this type of agrochemical paraquat, they found that there was a similar presentation to what we are seeing in people with this type of chronic kidney disease. Then we move to the next slide, please. So this is one of the most important, or if not the most important, research done in the United States. This was done by Dr. Suchi Anand at Stanford. They did research using GIS mapping to track hotspots of kidney disease in California. The main message, or the conclusion about this study, is that they found that there are a few of unexplained end-stage kidney disease hotspots where the nitrate levels in water was above the state median. And this is very interesting, which is maybe or giving us some ideas or hypotheses about what can be causing this type of chronic kidney disease. And next slide, please. This is something that we just published a couple of weeks back, and we have this is a policy statement: kidney biopsies among persons living in hotspot of CKDU or chronic kidney disease. This is a position statement by the International Society of Nephrology Consortium of Collaborators of Chronic Kidney Disease of Unknown Etiology. So the main message here is that there are a few recommendations. We know that there are several places around the world where people are suffering from chronic kidney disease of unknown etiology. We think that the way to advance the field could be by trying to understand this disease. So one of the recommendations is doing kidney biopsies for clinical indication, and consider that routinely in cases of suspected chronic kidney disease. And the rationale is that we don't know what is the diagnosis without a kidney biopsy. So the kidney biopsy is an important part of the diagnosis of any type of chronic kidney disease. The kidney tissue or kidney biopsy can give us some prognostic data. And the other recommendation is standard of care for kidney biopsy safety must exist when offering kidney biopsies. This means ultrasound guidance, biopsy gun, trained nephrologists or radiologists, biochemical and bleeding risk profile review. And the rationality for doing this is that there is a decreases the risk of complications when these conditions are met, regardless of the resource setting. And then another recommendation is a standard clinical data inclusive of occupational history and residence, biopsy processing protocol, and pathology review. Output should be gathered among all the persons undergoing biopsy for any reason in CKDU endemic region. So the rationale is standard minimal data sets and pathology scoring approach will enable optimal use of available clinical data with a minimum of additional resources. So now we can move to the next slide. So before mentioning the key takeaways, some of the large studies being conducted right now, there is the CURE consortium who is currently being conducted. Is an NIH-funded study, and it's conducted in multiple sites around the world. And basically all the researchers that have been doing research or are doing research on CKDU around the world, they gather together and now they are conducting this study. They are just starting, and this will be very interesting, exciting to see. So the key takeaways: there are several hotspots of chronic kidney disease around the world. The epidemiology and clinical presentation are similar. There is no proteinuria, there is no protein in the urine, no blood in the urine, and the tissue diagnosis is interstitial nephritis, but the etiology or the cause is still unknown. There are several hypotheses mainly focused on environmental factors. There is evidence that there is CKDU or chronic kidney disease of unknown etiology in the United States. There are a few preventive strategies that are focused on safe water source, heat stroke prevention, and eliminating potential nephrotoxins in the environment. In the United States, as mentioned before, there is evidence of chronic kidney disease of unknown etiology or ESRD, and there are some environmental factors as well. So people who have chronic kidney disease of unknown etiology, I think that we should consider doing a kidney biopsy. And the reason is that we can provide more information to the patient or family members as well. Next slide. Yes, so I encourage you to visit the International Society of Nephrology. We developed this this observatory of CKDU, and there is a lot of information about the clinical trials. Thank you.
Thank you so much, Dr. Garcia. I really appreciate your presentation. Finally, I'd like to introduce Dr. Robert Montgomery, who is here with a very timely presentation given the news of the transplanted pig kidney that came out yesterday. Dr. Montgomery is the chairman and professor of surgery at NYU Langone Health and the director of the NYU Transplant Institute. He is considered a world expert on kidney transplantation for highly sensitized and ABO incompatible patients, and is referred to the most complex patients from around the globe. Dr. Montgomery received a heart transplant in 2018 and is known for advocating for transplant patients. I'd like to turn it over now to Dr. Montgomery to share his work with xenotransplantation.
Thank you for that, Michael. As mentioned, there was a landmark development yesterday in the story that I'm going to be talking about today, which is xenotransplantation, or transplantation between two species. And much of what I'm going to be talking about is the lead up to what happened yesterday. So the title of my talk is Solving the Organ Shortage Crisis in Transplantation. I'm trying to advance my slide here. And it's not cooperating. Are you able to advance on your end? Well, Houston, we have a problem. Can you guys pull up the slides by chance? Oh, here we go. Okay, am I controlling that, or are you? Okay. All right, these are my disclosures. And the ones that are highlighted are relevant. Next slide. Okay, so just to give you a sense of the dire need that I'm discussing here today, I just want to go over a couple of inconvenient truths. So each year, about 1 million new patients are diagnosed with heart failure in the United States. I was one of those patients in 2018. Heart failure has a 50% mortality rate at 5 years. Last year, we did less than 4,000 heart transplants. So the definitive treatment for heart failure is a heart transplant, but we were only able to offer that to a very small percentage of the patients who could have benefited from it. And that's because of the organ shortage. It's no different in kidney disease and in kidney transplantation. So there are 800,000 people in the US with end-stage renal disease. About 82,000 are lucky enough, only 10% of the people who have end-stage renal disease are lucky enough to make it on the list. And only a third of those patients will actually receive a transplant. So this is the dire shortage in organs. We know transplantation is the best solution for end-stage renal disease. But unfortunately, with our current paradigm of someone having to die for someone else to receive a transplant, or having to give one of their kidneys, this is the crisis that we're facing. Next slide, please. So some more revelations and inconvenient truths and awareness of what I think is a pretty prevalent flawed thinking. We spend a lot of money trying to improve on it, which makes sense, on the dearth of organs that we actually have. But unfortunately, what we're up against is that much less than 1% of the people who die every year die in a way that could result in organ donation. And living donation, which for kidney transplantation is something that could be expanded, has been absolutely flat in terms of the number of transplants each year for the last 15 years. There are about 5,000 transplants each year from living donors. But for whatever reason, and despite the fact that we've really innovated, improved the operation, done a lot of great things to make it easier to donate an organ, the number of people who donate each year has remained the same. Our current donation rate in the US actually exceeds Spain. So Spain's always held up as the model of organ donation. And what I would say is really there's no change that we could make in our system, even things like changing to a opt-out or giving families and donors incentives, paid donation, that will likely change the organ availability in a way that would allow the people who could benefit from a transplant to fully realize that benefit. So given our inadequate supply of organs, I see that the only way out of this crisis is to identify a sustainable alternative source of organs. And that's what you heard about yesterday. Next slide. So there's a couple of ways that look promising in terms of building an unlimited sustainable supply of organs. Bioartificial organs, so these are, organs that come from, it could be from pigs, that the organ is decellularized and then recellularized with human cells or 3D printing. And then the other is xenotransplantation, where pigs are cloned after gene edits are made to make them more acceptable to humans. And this, I think, is the sort of the wind and the sun of of organ availability in the future of transplantation. Next slide. So, most of the work in xenotransplantation up until very recently was all done by transplanting gene-modified pig organs into primates. But the question is, how translatable is that work to humans? And I think a key step that we performed in 2001 to get the first organs into humans was to identify a group of individuals who suffered brain death, had wanted to donate their organs, but for whatever reason, their organs weren't suitable for donation. And so instead, the family was approached and they underwent whole body donation, in which the decedent is what we call someone who's brain dead, but their heart's still beating and they can be maintained on a ventilator for a considerable period of time, where we could test something like xenotransplantation and de-risk xenotransplantation, so our regulatory organizations would think that it was, ready to move into living humans. And so that's what we did. Next slide. And so the first gene-edited pig-to-human transplant occurred in September of 2021 at NYU Langone Hospital and we place this kidney on the blood vessels that are in the groin. You can see on the right side, the right screen, so that we could observe the kidney, because we were only going to, we only had permission to do this for 3 days, and we could take frequent biopsies, look at the health of the kidney, measure the urine. You can see on the left side, there's a little bag there, and that kidney is making urine underneath the silo there and functioning very well. Next slide. And then we moved on, and unfortunately, because for technical reasons, you're not going to be able to see this, but it was a nice video of the 2 xeno heart transplants that we did into brain dead decedents, where we tested really complicated gene edits, a total of 10 gene edits that made those hearts more acceptable to a human, and they function extremely well for 3 days, which is as long as we were allowed to observe them. Next slide, please. And then we went on to do a much longer test where, again, we took a gene-edited pig kidney from a pig and transplanted it into a brain-dead decedent who had donated their whole body for the purposes of these high-stakes studies to try to make it safer for xenotransplantation to move into living humans. And we observed that kidney in that decedent, again, in an ICU where their heart was beating, and they maintained relatively normal physiologic functioning. You can, maintain a body for a long period of time without any brain activity. I know that's a surprising thing, but it's well known. And again, we transplanted this kidney into that individual. Next slide. And it functioned extremely well. There was a rejection episode that we were able to treat. And you're probably aware that there have been 2 heart transplants in living humans, and both of those individuals were in very dire circumstances and died after about 2 months. And so that really comes down to, how do we define success? The first human-to-human heart transplant that was done by Christian Barnard in South Africa only lasted for 2 weeks. The first pig-to-human heart transplant in a living human lasted for 2 months. So we're at the beginning of this journey. But again, the news yesterday of a kidney being transplanted into a living human is very exciting. We'll follow that closely, see how that goes. I think in 2025, we're going to see the first clinical trials that will enroll, somewhere probably around 10 patients, living patients, to receive gene-edited pig kidneys. Next slide. And I just want to acknowledge our whole team. This kind of work is very complex and requires a major effort by a very large team. Thank you for your attention, and we'll now start our panel.
Thank you so much, Dr. Montgomery. That's really, really great. And I know even before you started, there was some conversation happening in the chat. So people are very, very excited about hearing your talk today. Dr. Farooq, I want to come to you with a first question. We've got about 5 minutes, so if I try to get a question to each of you, if for someone that's listening to this, and because there is some limited research on transgender care and transplant now, what would you recommend to transgender patients for trying to get involved in research and trying to move the field forward?
Yeah, I think that's a great and a really important question. It's not only an area where we need more research, but our current research, our data collection, I think can be better collecting data about sexual and gender minority individuals. Also, one example of that is if you are, collecting demographics on sex, it should be more than male and female, opening up those options so we can first understand, where these people are and then understand what their health conditions are. I'm hoping in the future that there will be more opportunities for research in this area and more transparency. But it's a little bit of a loop because we have to make people feel comfortable to share this information and to ensure that there will not be other consequences to them. And that all comes with creating an inclusive environment, not only in our clinical spaces, but also beyond that.
Great. Thank you so much. Dr. Garcia, a question for you. One of the sessions we had yesterday talked about patients that just have not been able to get a cause of their kidney disease figured out. And that last slide you showed with the prevalence in California, how do we know the difference between patients where, the workup just has not been done versus those who just, the workup has been done, we can't figure it out? Like, where's that line for CKD-U versus CKD that the cause hasn't been figured out yet?
Yes, very good question. So in nephrology, unfortunately, we don't have a lot of a testing other than the biopsy. I will say that a kidney biopsy might be the best way of determining the cause, or at least get to the bottom of the etiology of the kidney disease. When we see a lot of people who were diagnosed with advanced kidney disease without an etiology of kidney disease, and then unfortunately, once the patient has end-stage kidney disease, there is a lot of risk in doing a kidney biopsy because perhaps the kidneys are smaller than normal. So that's the part where we are missing, and unfortunately, we cannot do much more than doing some epidemiological studies. But as a community of providers, we need to improve in getting to the diagnosis and try to do what is best for the population with kidney disease in the world, in the United States as well.
And Dr. Montgomery, I'll come to you for the last question. We're getting lots of comments in the chat. Just, when is this going to be available to me, right? We've got patients on dialysis and that are asking that question. What's their best sense of that? And what can we do as a community? What can patients do to try to help move this forward any way we can? Yeah,
I'm going to start with the last part of your question. What you can do is advocate for yourselves. And I know that's hard to do because those of you who have received a transplant are just really grateful for whatever sacrifice had to be made for you to get a transplant, whether it was a living donor or a deceased donor. But you're the ones who really have a voice, and those of you who are waiting for a transplant. And I think we don't have our voices heard as well as we need to. And the people we should be talking to are the people in Washington, the NIH, the FDA. These are the folks who really set policy. And advocacy is the key to this. This is something that is it has been. We've been doing this research for 30 years, and we just now are getting into clinical use of it. And if you think of HIV and how rapidly the drugs were discovered in HIV, it was because the patients really advocated well for themselves. And I know many of you are sick and you don't feel well, and that's a difficult thing to do. But energizing your family members, your physicians, it's all about advocacy. I think within 5 years from now, we'll have completed the clinical trials that will then allow us to begin to move this into wider use. So that would be my prediction.
Excellent. Well, unfortunately, the time has flown by for these talks today. I want to thank our panelists. I want to thank our audience. Stay tuned, because next up is a continuation of this same topic. We'll have another 4 speakers coming up. Once we conclude this half of the session, you will see a poll for a quick survey pop up. Please fill that out. Let us know how we're doing. Your feedback is very useful for us as we plan future sessions. Thanks again, everyone. We'll see you in just a moment.
Thank you.